Those are yours. I'm in the wrong spot. Closet. Where that goes.
Yeah, I'm not for real.
Yeah. Oh, that's haircut.
They leave Thursday.
Yeah. You need to do something like that.
Yeah.
And I wear this.
Okay.
It's all over the place.
Once you have the video of the pharmacist interview and document uploaded, is that done? Okay. So then on the schedule when it says interview pharmacist for the Friday, is that just a turn in date?
Yeah, because we were supposed to do the presentations, kind of bleeding over into Monday. If you don't get it in until Monday.
Right. So that's not like an actual like thing where you go from last.
Yeah, no, we were encouraged at the beginning of the semester. Not that soon.
All right.
So we're just trying.
I think the schedule is.
All right. Okay, gang, time to get started. The papers to return to you are up here. There's never enough time before class to turn them all back. When I don't turn back, I'll get to Mrs. Schaefer. And if you could please see Mrs. Schaefer pick up the papers. And don't forget your tests are also with Mrs. Schaefer as well. Everyone knows where Mrs. Schaefer's office is, right? Good, okay. So go see Mrs. Schaefer and she will get your stuff. She should be in the office pretty regularly these days. Except Friday. She won't be there Friday. But next week she'll be there pretty much all week. So, all right. Okay, so last time we were talking about the two arms of the metabolic your metabolism. That's the arm where you make stuff, the arm where you break stuff. The arm where you make stuff, that's anabolism. The arm in which you break stuff, that's catabolism. What determines whether you'll do one or the other depends upon a mix of hormones. Some of these hormones are more specific for one molecule rather than the other. Some are a little bit one, a little bit the other. A good example is growth hormone. Growth hormone is very pro-protein, but growth hormone is very anti-fat. And growth hormone also prevents you from taking up sugar. So it's kind of straddles a little bit. Same thing with thyroxine. But the big message with all this is that insulin is the ultimate metabolic hormone. Insulin tells you to build all three molecules: fat, protein, glycogen. Insulin induces the formation of all three molecules. Glucagon very much opposes the effects of insulin. So whereas insulin will promote the formation of glycogen, glucagon induces the breakdown of glycogen into free glucose monomers. Whereas insulin promotes the synthesis of fat, glucagon induces the breakdown of fat. With regard to protein, glucagon has really no effects on protein. So for 2 out of 3, glucagon opposes the effects of insulin. And this table here simply summarizes the physiological effects of each of these hormones with respect to the various metabolisms: carbohydrate, protein, lipid metabolism. The two I want you to take home from this are insulin and glucagon. You'll notice they're pretty much opposed to each other across the board, except for protein metabolism. Glucagon has no direct effect on protein metabolism, but for everything else, they oppose each other. That's the one part I need you to realize here. Now, something about growth hormone that I want you to see is that growth hormone is going to decrease glucose utilization. That's going to be important when we talk about something called the dawn effect when it comes to type 1 diabetics. Type 1 diabetics are going to go to bed with a blood sugar. They're going to wake up with a higher blood sugar, even though they're not eating, because during the night you secrete growth hormone. It's especially a problem in children who will wake up with high blood sugars because their body's making growth hormone, and growth hormone tells their cells, don't take up glucose. So any glucose their body releases doesn't get taken up by cells because of that growth hormone. Not so big a problem in adults, bigger problem in diabetic children. So this picture graphically represents what was being said before. You have a liver cell, you have a fat cell. Both of these cells are stimulated by insulin to take up glucose and make glycogen. In the case of the liver cell, take up glucose, turn it into fat, take up free fatty acids, turn it into fat, store fat, insulin promotes both of these. If there was a muscle cell over here, it would say amino acids come in, make protein, insulin stimulates that too. Glucagon does the opposite. Glucagon stimulates the breakdown of glycogen to glucose, which is then released into the bloodstream. The liver is the only organ in the body that releases sugar. All your other organs, when they break down glycogen, they keep that sugar in the cell and they use it for themselves. Liver is the only organ that will release sugar, the only one. Fat cells, in response to glucagon, they degrade fat and they release free fatty acids. They degrade fat, release free fatty acids. And glucagon does nothing to skeletal muscles. So these hormones are made by the pancreas. Pancreas is a two-tone organ. It's part exocrine and it's part endocrine. Endocrine cells release hormones straight into the bloodstream. Straight into the bloodstream. Exocrine cells secrete their products into a ductal system. So this ductal system consists of these little grape-like clusters. They're called acinar cells. They form a so-called acinus. It's that little grape-like thing, the berry of the grape. That's an acinus. No improvement. Okay, just have to accept what I get. And the acinus makes all the enzymes and the bicarbonate for which the pancreas is famous. It secretes them into a system of small ductal tree-like structures. They merge into the common pancreatic duct, which then releases these through the duodenal papilla into the blood. Islands in between these acinar cells are these pancreatic islets, also known as islets of Langerhans. Those will release their hormones straight into the bloodstream. They don't release them into the ductal system, they release them into the bloodstream. Therefore, those are endocrine cells. Endocrine cells. There's two main types of cells in the pancreatic islet. There is an alpha cell. The alpha cell secretes glucagon. Glucagon. It secretes glucagon when glucose levels are low. Then there are the beta cells. The beta cells secrete insulin when glucose levels are high. So let's say you get up, you go to the DC, you have a waffle. You have waffle with syrup and a glass of milk, let's say. So that waffle is degraded to complex carbs, mainly starch, are degraded to sugar. Sugar is absorbed by the GI tract into the bloodstream. That raises the blood glucose levels. Now you will release insulin. That will tell the cells to take up the glucose and do something with it. Make glycogen, make fat, store protein, what have you. When those levels are low, let's say you go to class, you go to chapel, you study, you go to the gym, whatever, 12 o'clock rolls around, you're now in the post-absorptive stage, your body's releasing glucagon. That stored glucose is now being released, and it's giving you energy so your body can function. So these cells, if we were to kind of take a cartoon of them, here's the islet. The islet is an island in between the clusters of acinar cells. These are organized around a duct, your blood vessels like this, and here is your islet. The islet cells are always close by blood vessels, like here, so on and so forth. So they secrete their materials straight into these blood vessels. So here's a beta cell, and here is an alpha cell. Beta cells are kind of in the light, very, very light purple, and the darker purple, you have the alpha cells. Remember, alpha cells make glucagon. Beta cells make insulin. Now, your blood glucose is controlled within a very specific homeostatic range. And if you haven't eaten, a normal blood glucose level is anywhere from 65 milligrams per deciliter to 100, 101, 102, 103, 104, 105. When you eat, so you have that waffle, let's say, with syrup, now your blood glucose level is going to climb. It's going to climb above this level. But then your body secretes insulin, and your blood glucose level will now start to come back down. And so the glucose tells the beta cells make insulin. That high glucose will prevent alpha cells from making glucagon. That stimulates the uptake and use of glucose. That drops glucose levels. Now the beta cells will stop making insulin. And as the glucose level starts to decline, when it gets to a certain level, now those cells will make the alpha cells will make glucagon. When you don't eat, when you're in the post-absorptive stage, you have lunch at 12:30, you have class and what have you, you eat dinner at 6:30. Round about 4 o'clock, 4:30, something like that. Your beta cells stop producing much insulin. Now your alpha cells release glucagon. Now you have the cellular uptake of glucose that is decreased. You have the degradation of glycogen and now the synthesis of glucose from small molecules called gluconeogenesis that raises blood glucose levels. And now, as those glucose levels go up, glucagon levels will start to decrease as those glucose levels start to climb. So in a non-diabetic, that rise of glucose from your meal will climb, and it will usually get to the ballpark of 170 milligrams per deciliter. It will be below 200. That's kind of the number that clinicians look for. If your glucose gets above 200, that's a sign you don't have proper regulation, or you've really, really pigged out on some very, very glucose-rich foods. So this play between insulin, glucagon, insulin, this rise and run from the fasting level to the non-fasting level, back down to the fasting level. That essentially describes the homeostatic process by which glucose goes up and comes down and what have you. So this is insulin after it's made by your beta cells. So insulin is originally made as a single polypeptide like this. The bit that is found in the mature molecule is in the red. The bit that's in the silver, that's called the C peptide. C for Charlie. C peptide. That is clipped out. That gives biologists a very nice way to detect how much insulin cells are making, because you can make really high affinity antibodies to the C peptide, and that will tell you exactly how much insulin that cell is making. Because once you secrete insulin to the outside of the cell, you can find it, but it's a little harder to detect This thing is dead easy to detect. That's a C peptide. These other two peptides, you can tell they're linked together by these disulfide bonds. So insulin is a protein that is secreted by beta cells, but it undergoes quite a bit of processing before it's released. So what binds to the insulin receptor is this piece here. And this is called the A peptide. This is called the B peptide. And that's called the C peptide. So the effects of insulin in the body are to, number one, promote storage of the products of digestion, fat, protein, glycogen, inhibit the breakdown of fat and protein, inhibit the secretion of glucagon. Glucagon and insulin reciprocally regulate each other. So high glucose levels promote the release of insulin. Insulin will also tend to shut off glucagon. Low glucose levels induce glucagon, and the glucagon will also tend to shut off insulin. And also stimulate the uptake of glucose in skeletal muscle, liver, and fat. They do this by causing the insertion of a transport protein into the membrane called GLUT4. GLUT4. GLUT4 is a glucose facilitated diffusion transporter. When a cell has GLUT4 in its membrane, it can, excuse the expression, pig out on glucose. It can take up tons of glucose without expending energy to take it up. And these three types of cells, skeletal muscle, liver, fat, they pig out on glucose. The muscle will store it for a rainy day in the form of glycogen. Liver will too, but if it's anaerobic muscle, an anaerobic muscle will just use the glucose directly. And this fat will take it up and use it to make fatty acids and store fat. GLUT4 is made and is packaged into vesicles that don't fuse with the membrane unless the cell gets an insulin signal. When it gets an insulin signal, the vesicles fuse with the membrane. GLUT4 will now allow the massive uptake of glucose. This is one of the reasons why insulin stimulates the lowering of blood sugar levels. It stimulates the uptake of glucose by cells. This is the insulin receptor. The insulin receptor is a member of the protein tyrosine kinase family of receptors. The receptor tyrosine kinase family of receptors. So this binds insulin. This activates the tyrosine kinase activity, and you get phosphorylation of target proteins on their tyrosine residues. And the main target is this protein here, the insulin receptor substrate protein. The insulin receptor substrate protein, otherwise known as IRS. This does not mean Internal Revenue Service. This means insulin receptor substrate. This protein is encoded by a gene that was first isolated, well identified in the fruit fly, and mutations in that gene make flies that were very, very tiny. So because they were discovered in a lab in Spain, they gave them a Spanish name and they called them Chico, which Chico normally means boy, but it also in colloquial Spanish means, oh, you're so little, you're so cute. And so they were cute little flies, so they called them Chico, and the name stuck. And so even some of the people who do work in mammalian tissues will still call this cheaper. And in deference essentially to the work done in the fruit fly. So this is the protein that then goes on to activate two pathways in the cell. The MAP kinase pathway and the PI3 kinase pathway. Notice they're both kinase pathways. What do these do? This pathway promotes growth and survival. Growth and survival. This pathway promotes metabolism. Metabolism. So you have two arms of insulin signaling, growth and survival and anabolic metabolism. They're both induced by insulin because the one receptor through IRS1 will activate both these pathways. So essentially through the sorts of proteins that this receptor activates, you get glucose transport into the cell, stimulation of protein synthesis, fat synthesis and storage, glucose synthesis and its storage in the form of glycogen, and growth and gene expression. And this is one of the reasons why diabetics whose disease is not well controlled will undergo this wasting, this terrible wasting that in medical terms is called cachexia. Cachexia. It's a wasting. You see it particularly in children, but you'll also see it in adults with poorly controlled diabetes. They will get very, very thin. You'll see their bones. They will lose tremendous amounts of muscle mass. Their skin will get very tight and taut and thin. Their hair falls out. Their mucous membranes now look bleached. Their eyes look sunken. That's cachexia. You see that too in cancer patients with cancers that just draw enormous resources from the body. But that's due to the fact that you don't have this pro-growth, pro-synthesis, pro-survival program going on in cells. So this shows you how GLUT4 gets put into these little vesicles, and these little vesicles hang out underneath the membrane. And there they will stay until you get an insulin signal. When you get an insulin signal, these vesicles, lickety-split, will fuse with the membrane. Now they'll bring in glucose very quickly into the cell. Without these, glucose entry into the cell is sluggish and slow. When GLUT4 gets put into the membrane, now glucose comes in very, very quickly. Again, I'm just trying to beat a dead horse, just to try to get you to see that everything anabolic in the cell is induced by insulin signaling. Glycogen synthesis, glucose transport, protein synthesis, cell division, metabolism and storage, blah, 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 blah. You get the point. I think I've beaten the horse well enough. So what kind of readout then do you get from insulin? This shows you a so-called oral glucose tolerance test. This is the gold standard test for diagnosing diabetes. Those of you who've had human physiology from me have participated in this test. So you fast for 12 hours. You go to the lab in the morning. They give you glucola. This is a 25% glucose drink. It's disgusting. You will drink 4 milliliters per kilogram body weight. Before you do that, they take your basal glucose level. Then you drink it, and every half hour, they then take your blood glucose level. Now, in a non-diabetic, your blood glucose level will go up, then you make insulin. So here's plasma insulin, here's blood glucose. The blue is a non-diabetic, the red or maroon or burgundy or whatever color you're seeing there, because that's a different color than what I'm seeing here, is that's a diabetic. So here it goes up, you make insulin, and then the glucose level goes down. You have this homeostasis where the blood glucose level varies within a very discrete level. In a person with diabetes, type 1 diabetes, you don't make that insulin. The blood glucose level soars and it comes down very, very slowly, if at all. So that shows you how insulin will cause glucose essentially to come barreling down because of these effects it has on the cell. Let me pause here, see if there's any questions about the effects of insulin on cells or on the body, anything like that. Then let's go to glucagon. Oh, incidentally, if this test is being performed on a woman who's pregnant to see if she has gestational diabetes, you'll only fast usually for 6 to 8 hours, and then you'll take the test. That way, because fasting is very hard on a pregnant woman. So they only ever fast for 6 to 8 hours. Glucagon. So glucagon maintains the blood glucose level above 50 milligrams per deciliter. Everything that insulin does, this does not do. It does essentially the opposite of insulin. So think of glucagon as the anti-insulin in some ways. It stimulates the degradation of glycogen in liver. That's called glycogenolysis. It stimulates the synthesis of glucose from small molecules. It stimulates the degradation of fat and the release of fatty acids. And it stimulates the conversion of those fatty acids into so-called ketone bodies. So the fatty acids are oxidized to acetylcoenzyme A. You use acetylcoenzyme A to make beta-hydroxybutyrate, acetoacetate, and acetone. Those are the 3 ketone bodies. Those can be used as a carbon and energy source by cells in lieu of glucose. Even your brain. Your brain doesn't like it, but it can use it. And your skeletal muscle, heart, liver, kidneys, and yes, even the brain can use fatty acids. Well, they use fatty acids for energy. They all can also use ketone bodies for energy as well. So again, showing this graphically, the liver will release glucose, skeletal muscle, because it's not receiving a signal to make protein in the morning, you will release high levels of glucocorticoids. Those will stimulate the release of amino acids. Those amino acids are used for gluconeogenesis. Gluconeogenesis is also stimulated by glucagon. You release ketone bodies, and then adipose tissue will release fatty acids. Those will be used then to make ketones. The nervous system can also influence the release of insulin and or glucagon. So the pancreas is innervated by the autonomic nervous system, and the parasympathetic nervous system will tend to stimulate insulin secretion. That shouldn't surprise you, given that parasympathetic nerves are involved with digestion. That's the rest and digest response. Sympathetic innervation will inhibit insulin and stimulate glucagon. That can cause so-called stress hyperglycemia, stress hyperglycemia. So years ago, people discovered if they injected mice with sugar, they get this much insulin made. If they fed mice the same amount of sugar, they get this much insulin made. So there was something about sugar passing through the GI tract that increased the insulin response. Nobody knew what it was, and then folks started looking at hormones made by the intestines. And it turns out there's a group of cells called L cells in the small intestine. L cells, they secrete small molecules that sensitize the pancreas, well, the pancreatic islets, to sugar. Therefore, because these peptides sensitize the pancreas to sugar, you get a much more robust insulin release when you take up the sugar than when you get it injected. So these peptides, this one was originally called the gastric inhibitory peptide. It's not called that anymore. It's now called the glucose insulinotropic peptide. That's harder to remember. Just call it GIP. Glucose insulinotropic peptide, GIP. The other is the glucagon-like peptide 1. Glucagon-like peptide 1. It's called glucagon-like because it's really short, just like glucagon. And then cholecystokinin also stimulates, that's made by the duodenum, that also stimulates insulin secretion, but the big guns are these two, GIP, GLP-1. So those two molecules, GIP-1, GLP-1, those are called incretins. Incretins. Those are going to be important when we talk about medicines. Because several medicines for diabetes are going to play off the incretins. So this essentially summarizes everything we've talked about so far. When you eat that waffle with the syrup, oh, every time I say that, you look at me like you're hungry. You really like waffles or something? You do. Every time I say waffle, you look up. Your insulin is high, your glucagon is low after you eat that waffle, and that will cause formation of glycogen, fat, and protein. Glycogen, fat, and protein. Therefore, blood glucose goes down. And these other things go down too because your cells are taking them up. But the one I really want you to pay attention to is glucose. When you then go 4 hours, I know, Corinne, you tell me, at least you told me in genetics, I don't know if this is still your routine. You go straight from class to cheer practice, you don't eat dinner till after. Is that still your routine? Yeah, so Corinne probably goes 6, 7 hours without eating. Depending on when you have lunch, that is, if you remember to have lunch, because remember sometimes you tell me you forget to eat lunch, and in which case it might be even longer than that. So using Corinne as our example here, her body, while she's at chair practice, jumping and running and climbing on people and putting her life in their hands, as a catcher, what have you. Now, glucose is falling, so insulin is down, glucagon is up. That's going to cause release of fat, release of glucose, production of ketone bodies, and therefore glucose levels will go up, amino acids go up, fatty acids go up, ketone bodies go up, and what have you. All right, so that's kind of our transition from what these hormones do to what happens when those hormones don't work. It's a good time for questions. All perfectly clear. All right. So diabetes mellitus. There's two types of diabetes. Diabetes insipidus and diabetes mellitus. Diabetes insipidus is due to an inability to make sufficient quantities of antidiuretic hormone. Antidiuretic hormone is released by the posterior pituitary. That's a different disease than diabetes mellitus. Diabetes mellitus. So there's two types of diabetes mellitus, type 1 and type 2. Type 1 diabetes mellitus is due to destruction of the beta cells. So if any of you know Amanda Bach on campus, one of my biochemistry majors, Amanda Bach is a type 1 diabetic. She has an insulin pump, just constantly having infusions of insulin for her to live. Her pancreas doesn't make sufficient quantities of insulin. She's type 1. Type 2 diabetes is due to insulin not working. You make enough of it, but your cells are resistant to it. The insulin bounces off your cells. So it's due to a lack of an effect of that insulin. So type 1 diabetes mellitus is very much an autoimmune disease. The immune system attacks the beta cells and destroys them. Because it destroys them, you don't make sufficient quantities of insulin. Sometimes that happens very early in life. Other times, a viral infection can induce it later in life. I've known people who became diabetics at age 39 because of certain viral infections. They can happen. Cancer patients who have certain cancers, those cancers can destroy the beta cells. People with trauma to the pancreas, the pancreatic enzymes can just dump, and those can destroy the beta cells. There are other ways you can become type 1 diabetic. Point of type 1 diabetics is it's usually early in life when you become type 1 diabetic. There are about 5 to 10% of diabetics. The development of ketoacidosis, which we'll talk about later, is common in type 1 diabetics. And they must treat themselves with insulin injections. Type 2 diabetics, you tend to be older when you develop type 2 diabetes. There's a trend now with childhood obesity. Unfortunately, you're seeing it earlier and earlier, but you do tend to be older. The vast majority of diabetics are type 2 diabetics. Type 2 diabetes is linked with obesity. It's linked with obesity. That doesn't mean there's not a genetic component to type 2 diabetes. There is. Clearly, there is. But in this case, your medication will be very different because you're taking medications to sensitize the body to insulin. Only later in life, as the beta cells become exhausted, do you usually need to give yourself insulin. Now, type 2 diabetics may have to give themselves insulin to start with because their blood sugar may be really high. The only way it's going to come down is through insulin injections. But you'll get weaned off those insulin injections as time goes on. So type 1 diabetes, the onset tends to be kind of rapid. You get kids, it's usually kids, they lose weight, even though they're ravenously hungry. Also, the symptomatology of diabetes is the 3 Ds. The 3 Ds, 3 Ps, sorry. Polyphagia, always eating. Polyphagia, always eating. Polydipsia, always thirsty. Polyuria, always having to go to the bathroom because you're drinking so much. Polyphagia, polydipsia, polyuria. That's your unholy triad of symptoms for diabetes. Now, let me just give you one example from my colleague. Tom Kunzelman, as you guys know, is married to a nurse. She knows this better than I do. Yet when her own kid became diabetic, she missed it. Why did she miss it? Because she was too close to it. That's why in medicine, you have to always keep your objectivity. Are you concerned for your patient? Yes, you're concerned for your patient. Do you care for your patient? Yes. If they die, will you cry? Yes, I hope you do. But you must keep your distance. If it's your own kid, don't treat your own kid. Get someone else to. Recuse yourself. You're too close. If you don't believe me, talk to Melanie Kunzelman. She'll tell you. She could recite this litany in her sleep, yet she missed it because she was too close. Yet she is as good a nurse as you will ever meet, but she missed it just because when you sacrifice your objectivity, you will miss things. So take that to heart. In fact, if you're not going into medicine, write it down. Right? Okay, so you have this lag between glucose use, fat synthesis, what have you. You get this massive production of ketone bodies. Those ketone bodies are organic acids that drops the pH in your blood. That's called ketoacidosis. This is a potentially very dangerous situation. With that ketoacidosis, the body will try to correct it by hyperventilating. You get what's called cruise-small breathing, panting. And that panting is a desire to get rid of CO2, because by getting rid of CO2, you can essentially create more acid in the blood. So you have increased glucagon levels that stimulates breakdown of glycogen in the liver and also the synthesis of glucose by the liver. So you start releasing glucose into the urine as well as these ketone bodies. With the loss of those ketone bodies and that sugar, you're losing more water and you're losing more electrolytes. So that could cause severe dehydration and also electrolyte loss with the metabolic acidosis. Gang, if this isn't corrected, your patient's going to fall into a coma, they're going to die. So if you have ketoacidosis, you need to, first of all, well, they need insulin, first place. Secondly, they need to take in enormous amounts of liquid with electrolytes. So first thing you do when they get to the hospital is insulin to IV. And if it's ketoacidosis, it's not that severe, and it's clear the patient doesn't need to come to the hospital, you say, make sure they get their insulin shot like they need. 2, they need to start drinking lots and lots of fluid to flush those ketone bodies out of the blood. That's going to be very important for their treatment. So type 2 diabetes mellitus, as we said, comes on gradually, and there's usually several stages. There's a pre-diabetic stage, there's a less severe and a more severe stage, depending upon your results in a oral glucose tolerance test. And then the amount of insulin that you'll produce in the pre-diabetic phase, you can see your beta cells are really working overtime to try to make more insulin to deal with the sugar. This is treatable by exercise and diet because exercise sensitizes your cells to insulin. In fact, exercise is one of the best sensitizers of cells to insulin that's known. And it turns out, studies have shown that light to moderate exercise is even better than heavy exercise. So, the old bromide, get a dog. What do you have to do to dogs? You have to walk them. So it forces you to take a walk. Right? You don't like dogs?
No, I find.
Yeah, because when I said dogs, you kind of looked at me funny. Just to say, no, I'm not getting a dog. I'm a cat person.
I just,
You don't like any animals?
oh, they're just ruin your stuff. You just have to pay money for them to live it.
Okay.
Yeah, I don't pay for it. That's why I have one, Jess.
Okay.
It's true.
Yes, but there's a trade-off, companionship. So, this exercise piece is really important. So is the diet piece as well. Now, type 2 diabetes usually is not accompanied by ketoacidosis, but you have insulin resistance, and that insulin resistance is the hallmark of type 2 diabetes. It occurs most often in people who are overweight or who are obese. There is an inherited tendency to develop type 2 diabetes, but it usually develops gradually. Reactive hypoglycemia is a condition, again, this runs in families, where people will take a high glucose meal and their pancreas just shoots out enormous amounts of insulin. And then the blood glucose level tanks. And by tanks, I mean tanks. So reactive hypoglycemia, in these people, they have to not eat foods that are very high in glucose, because they, within usually an hour or two, they'll just crash, absolutely crash. People with reactive hypoglycemia tend to be genetically predisposed to type 2 diabetes. Now, this sort of phenomenon is seen in some people. This is easily controlled by diet usually, but those people usually need to be watched for the development of type 2 diabetes. All right, so we said before that insulin will cause the GLUT4 transporter to get put into the membrane. That essentially is put into motion by the binding of insulin to the insulin receptor. So I don't want to go through the whole litany of proteins here and everything, but suffice it to say, you'll get glucose coming into the cell because of that. So the bottom line is glucose gets taken up because these cells put GLUT4 into their membranes. So high insulin gives you low blood glucose levels. No insulin or poor reaction to insulin gives you high blood glucose levels after a meal. So, for example, there's a little vignette we could tell. Let's say you had Dastardly Dan, who was going around the hospital injecting people with insulin. And these people were dying because of very low blood sugars. Let's say you caught Dastardly Dan in the act, and you tried to apprehend Dastardly Dan so hospital security could take him to the well-deserved pit that he deserves. But instead, he injects you with the insulin and gets away. You're starting to feel pretty woozy. What do you tell the nurse to fetch for you? Glucose. Glucose. Couple of sugar cubes from the coffee stand, you'll be fine. Glucose. You just need glucose. Now let's get back to glucose, insulinotropic peptide, and glucagon-like peptide, those incretins that are released by the L cells in the duodenum. These hormones increase insulin secretion. So here's this experiment that we talked about where you give intravenous glucose and oral glucose. You see the difference in plasma insulin concentrations. The reason that the oral glucose gives you more insulin is due to the release of these incretins. Those incretins are pre-sensitizing the pancreas to the increase in glucose. So this is called a feed-forward mechanism. A feed-forward mechanism. And the two main incretin hormones are the glucagon-like peptide 1 and the glucose-dependent insulinotropic peptide, or GIP. And those peptides can be mimicked in medicines. So these are made by L cells. They're secreted into the bloodstream. They go to the pancreas, and then they will prime the beta cells for that increased glucose. Now, it turns out incretins are regulated. They're regulated by a peptidase called dipeptidyl peptidase 4, or DPP4. DPP4 degrades the incretins. Because it degrades the incretins, it prevents incretins from overdoing it. But in a diabetic, if you wanted to increase the activity of incretins, you can inhibit this enzyme. And in fact, there are drugs that do just that. They inhibit DPP4. Therefore, you get more activity from your incretin. Therefore, you get more activity from your insulin. And so this will sensitize cells to insulin. And then we have the mainstay of diabetes treatment, and that is insulin itself. Now, insulin comes in several different flavors, and in your notes, you have a chart on page 107 of the different types of insulins. So you have the ultra-fast acting, otherwise known as the rapid-acting insulins. You have fast-acting insulin, which is just regular insulin. You have the intermediate-acting insulins. These are insulins that are mixed with a salt. So they have to dissociate from the salt before they can become active. Intermediate-acting insulins. And then the long-acting insulins. These are peakless insulins. Most insulins, you inject them, they have a peak, and then they decrease their activity. So they tend to do this. Long-acting insulins just have a baseline level, they're peakless. If you're using a pump, all your pumps use rapid-acting insulin. That's the only insulin they use. And diabetics today who are on pumps, they don't use any of these other insulins, they just use a rapid-acting insulin. For type 2 diabetics, you have drugs called insulin secretagogues. Insulin secretagogues. These stimulate the beta cells to release higher than normal levels of insulin. So your cells are resistant to insulin. You make these higher than normal levels of insulin. Now the cells will respond as they should to insulin. So there's two groups of these. There's the sulfonylureas and the meglitinides. The meglitinides have a very short half-life. So they're good for taking them before a meal, and then they act essentially for that food you took during the meal. They're very useful for that. Sulfonylureas tend to have a longer half-life. Because they tend to have a longer half-life, they're good more for maintenance of blood glucose levels. The sulfonylureas. These drugs are oral. Insulins have to be injected. Then you have the biguanines. This is the drug metformin. Metformin is the mainstay of type 2 diabetes treatment. It's very cheap. It's very well tolerated and it works, and it works well. So if you get a diagnosis of type 2 diabetes, this is the first drug that we put on, pretty much bar none, provided you don't have liver or kidney damage. So this will sensitize cells to insulin. It increases insulin sensitivity and prevents the liver from overproducing glucose. Very, very useful drugs. The biguanides, the only drug of which is metformin. Then there's these drugs with a forbidding name, thiazolidinediones. Oh, good night, who names these things? Thiazolidinediones. These sensitize cells to insulin. In particular, they sensitize fat cells to insulin. But they also stimulate insulin sensitivity in other cells too. So they restrain hepatic gluconeogenesis, they increase muscle and adipose tissue metabolism, and they increase glucose uptake. The thiazolidinediones, just abbreviate these TZDs, TZDs, because thiazolidinedione, that's just too much to say. Then you have drugs that inhibit dipeptidyl-peptidase 4, the DPP4 inhibitors, otherwise known as the gliptins. These are also oral. These are oral drugs as well, the gliptins. So notice these drugs end in gliptin, sitagliptin, saxagliptin, linagliptin, allogliptin, your mother-in-law gliptin. These drugs improve the activity of incretins, and they will lower blood glucose by increasing incretin activity. They tend to be very well tolerated. Then you have drugs that mimic the activity of the incretins. They're incretin mimics. These are injected, except there's one that's come out now that's oral. These are not degraded by DPP4. And so they include exenatide, liraglutide, semaglutide, dualutide, notice they end in glutide. When you have that tide ending, that means they are an incretin mimic. These are injected. Some of these have now been approved as weight loss drugs. These drugs actually prevent the stomach from emptying very quickly. So they increase satiety. So they decrease the amount you eat and they cause you to lose weight. That's a big bonus because some of these drugs cause you to gain weight. Then you have the newer drugs on the block, the SGLT2 inhibitors. We saw these when we looked at heart failure. These work in the kidney to prevent glucose reabsorption. So you lose water, you lose sodium, you lose glucose. They lower blood glucose levels. They end in flozin, canagliflozin, empagliflozin, dapagliflozin, ortogliflozin. Gee, I wish this lecture would end with flozin. Drugs like that. And again, they work in the kidney. So your adverse effects will be things like dehydration, hypoglycemia, but you have a decrease in risks of heart-based adverse effects. So they have that added benefit. All right. Friday. So look at how to use these drugs clinically. Now, if you have assignments to hand in, they're due Friday. They're not accepted after Friday. The exception is the interview with the pharmacist. The interview with the pharmacist is due end of the day, Monday. End of the day, Monday. Okay? But extra credits or any assignments are due They're due?
Friday.
Thank you. Friday. They're due Friday. Elena, do you have any questions?
Is the grade book up to date?
Oh, boy, let me turn you up. You're
Oh,
really hard to hear. Okay, go ahead, say that again.
is the grade book up to date?
Mostly.
Okay.
What are you missing?
I think it was vocab 5 is in as a, I don't think there's a grade in right now, but I think I emailed it to you last week or 2 weeks ago.
Let me check on that, Elena.
Okay, thank you.
Yeah, right there.
Alrighty, have a good rest of your day.
Thank you, Elena. You too.
Do you need this at all for the interview with the pharmacist? Because I didn't turn it in online.
I already looked at that. I already graded it,
Okay.
so.